and we are still continuing with our eco sessions. We are still, sorry for the disturbance, we are still continuing with our eco sessions, and we are still treating the pharmacological and non-pharmacological management of pain series. So in our last session, we were looking at assessing the risk for opioids and substance abuse, which was presented by Pepile Sugati from the Psychiatric Center. And we also had a case presentation from Eswatini, our home original nurse. Today we will be looking at prescribing an opioid. The presentation will be coming from Lubombo Referral Hospital. So at this point, I would like for my colleagues to introduce themselves, and then you can also introduce yourselves in the chat box, but we'll start from my side.
Good afternoon, colleagues. My name is Pastor. Hospice.
Good afternoon, colleagues. My name is Eswatini, Hospice.
Afternoon, all of you. I'm slowly Melanie, Hospice. Thank you.
Afternoon, colleagues. My name is Sabet Ukele from Hospice at Home.
Afternoon and happy new year, colleagues. My name is Sandile Masano from Eswatini Hospice at Home.
Afternoon, colleagues. My name is Benedict Lamene from Eswatini Hospice at Home.
Good afternoon, colleagues. My name is Mangumele Rosane from Eswatini Hospice at Home, Eswatini.
Thank you for the introductions, colleagues. Can you also introduce yourselves? Can you start by Thandazile? Please introduce yourself, and if there's any other colleagues that you're joining with, can they also introduce themselves?
Good afternoon, colleagues.
Afternoon.
Yeah, it's Thandazile Simelane here, and as working in the palliative care department, the Manzini Government Hospital Oncology Unit. Today I'm alone.
Okay, thank you, Thandazile, for joining us today. Can we also have Mr. Mvila introduce himself?
Good afternoon, colleagues. Happy New Year. This is William Mvila from Lubombo Referral Hospital. I hope to be joined by Dr. Mwamba. We will be presenting together today. Thank you.
Thank you, Mr. Mvila. We are looking forward to that presentation. Can we also have Victorian Shabati? Please introduce yourself, Mhlabati. Okay, in the interest of time, we will move on to Bongile Makakula. Please kindly introduce yourself, Bongile.
Good afternoon. I'm Bongile Makakula from Pixby Government Hospital.
Thank you for joining us, Bongile. We are hoping that you will find this session very informative.
Thank you, and I'm alone.
Oh, okay. Victoria, please introduce yourself.
Morning, colleagues. I'm Victoria at Manzini Government Hospital.
Thank you for joining us, Mhlabati. If there's any other colleagues that you are joining with who will probably join during the course of the session, you can also introduce them in the chat box by writing their names, where they are working from, and also their email addresses. So as I mentioned at the beginning of the session, that today we are going to be looking at prescribing an opioid. I hope Mr. Mvila is ready on his side to give us the presentation for the day. Mr. Mvila, are you ready?
Yes, I'm ready. I'm ready to begin the presentation. Thank you very much, colleagues.
You can go.
Thank you. My name is William Villa. I'm a nurse here at Lubombo Referral Hospital. I'll be presenting on prescribing an opioid. We all have at some point prescribed opioids, or we have facilitated the prescription of opioids. So today we are going to look at how do we correctly prescribe an opioid. So the outline is as follows: the introduction, broad principle of opioid prescription, and how to write a prescription, and prescription requirements, then responsibilities of a prescriber, and then we will conclude and have some discussions after. So please have a pen and paper so that you can write, so that we can discuss some. I was hoping this was going to be interactive, more interactive than the other presentations, because it's something that is short. The presentation is short in itself, but there are many other details that we can have, or many other areas that we can touch on. So in introduction, we can say the prescription of opioids is regulated by the law. So there are acts and policies that are there in place that we should follow. First of all, there is a very old act. It's called the Opium and Habit Forming Act of June 1922. It stipulates that a medical practitioner, a dentist, a druggist, that's what they refer to pharmacists. They say they are druggists. A druggist and a veterinary officer are the only people who are responsible for prescribing or dealing with opioids under the Ministry of Health. Of course, now we know that the veterinary department is now under the Ministry of Agriculture. But then there were other acts that were promulgated after that act. That is the one that I laid my hands on, was the Medicines and Related Substances Control Act, which is Act 9 of 2016. There is also the scheduling of drugs, which was done in March 2019 by the government. And I also mentioned that there are policies and standard operating procedures that we work under as the Ministry of Health. The Health Facility Pharmaceutical Standard Operating Procedures. That one, if you read it, it does talk about medical practitioner, the pharmacist, pharm tech, and the nurses as people who are responsible for the scheduled drugs or the controlled drugs. So we still have other policies like the task shifting policy. So I didn't want to then say it's only the medical practitioners and the pharmacist and the dentist who are responsible for opioids. Even now we have nurses who are specialized, who are working directly with patients that need opioid prescription. They themselves can prescribe under the guidance of the medical practitioners, like nurses in ICU, nurses in anesthesia, nurses in palliative care. So we do have that understanding and those policies that are helping in covering the nurses to prescribe opioids if there is a need under the guidance of a medical practitioner or that program that they are working under. So these are the broad principles of opioid prescription. By the clock, that is, we give our opioids regular rather than PRN. If it's a 4-hour leak drug, you simply say every 4 hours, or QID. So there is no PRN for opioid or for analgesics in general. So we want to control the pain before it sets in, not to wait for the pain and then you start tackling or taking care of the pain after it has occurred. So we also say by the correct route for palliative care, it's oral. But for unconscious patients, of course, we give our pain medication, IV. We don't want IM most of the time. We try to shun away from IM because IM, it causes the pain on the muscle first before the patient receives the analgesic effect of the drug. So, but if there is no alternative, you can give it IM, you can give it subcut, depending on the setting that we are under. But for palliative care, we emphasize that to give it orally. So, and then by the patient, so individualized treatment of the patient. So we must have the weight of the patient. We must look at the condition of the patient and be careful with extremes in age. Those who are elderly and children, you should make sure that you calculate your dose very well. And by the WHO pain ladder, fortunately, I'm the one that presented this topic. When we talk of the pain ladder, there are 3 stages, step 1, step 2, step 3. So step 1, non-opioids and NSAIDs. Step 2, the weak opioids, NSAIDs, and the simple analgesics. Step 3 are the strong opioids, your morphine, your pethidine, your fentanyl, your NSAIDs as well, and then the simple analgesics. And in all the stages, you also give adjuvants. So that is what we follow when we are prescribing opioids. So make sure that you know when to prescribe opioids, in which step are you at, depending on how you have assessed your pain and what you want to treat as well. Thank you. Next slide, please. So we now look at other important principles of prescribing opioids. When you are prescribing an opioid, you should use pure drugs rather than fixed drugs. The example is paracodaine. We like to give paracodaine when we are treating pain. It's step 2 on the WHO ladder. So it's paracetamol and codeine combination. But are you aware that when you are trying to taper this or to titrate this, you may find that your paracetamol is now, you are now overdosing your paracetamol because you want to increase your codeine. You find that now the paracetamol in the drug is more than that. So we are saying if you prescribe opioids, make sure that you choose pure drugs. If you choose codeine only and paracetamol only, don't choose paracodaine if you are to treat very well, especially if you are to taper, to titrate up and down. So weak opioids and strong opioids should never be combined as they are competitive agonists in the same receptors. They fight for the same receptors. The kappa, the mu receptors, the receptors in the central nervous system. So if you want to step up to step 3 of the ladder, make sure that you have stopped your weak opioid, which is in step 2. Do not go along with the weak opioid. So because the weak opioids may decrease the efficacy of the strong opioid. So, and then the last point I've already alluded to it, that you should escalate your opioid dose rapidly until the pain is controlled, and then steadily taper down. Once you have reached your goal, steadily taper down and reassess the patient's pain score and make sure that the patient is still comfortable. Do not just cut the drug. Make sure that you taper down. Others will come and give us a clear lesson on this one. Why do we have to taper down gradually until we come to the end of those? So next slide, please. Next. Then how do you write a prescription of a patient? We will look at just 4 parts. First, you should have the patient's name, the sex, the race of the patient, the date of birth or age, and then the diagnosis of the patient. So, and then the medication and strength, amount to be taken, the route by which to be taken, and the frequency. So the amount to be given at the pharmacy and the number of refills. So if you have a prescription that you want to send to the pharmacy, make sure that they know when the patient is supposed to come back for refills, especially for other prescriptions that are continuous. And then the signature, stamp, and clinician identifiers like the qualification and the practicing license numbers. So pharmacists, they know when if the signature is there, because they do keep, local pharmacists, they do keep signatures for the prescribing, the prescribers of that institution. And then the stamp, the clinical identifiers, like I said, there are other health clinicians who are not supposed to prescribe, but there are those who are allowed by certain policies which are there in the pharmacy department or in that institution. And then the practicing license numbers, some institutions, they do require practicing license numbers, but for most institutions, just the stamp and the signature of the particular officer is enough. Next slide, please. This is a handwritten prescription. I hope you can be able to follow there. I tried to upload one from our institution, but it wasn't clear, so I decided to go with this one. So this example is a common medication prescribed when people are leaving the hospital. Actually, it's an eye laxative, a stool softener. It's 100 milligram tablet taken at bedtime. So the prescription is for 30 pills, and there are no refills. So no refills. 30 is written in numerical order and then in words. And then the route PO, the frequency QHS or Nocte, then it's 1 tab Nocte. So the name of the medication here and the strength. So you know that 1 tab is 100 milligrams. So make sure that when you write the prescription, it's a very clear prescription. So we'll look at that further. Next slide. Typed prescriptions are also accepted in pharmacies. So this one is an order for diamorphine, 30 milligram. The form is injection. So how many should you supply? 6, and then in words 6 ampoules. Then the patient will take 60 milligrams daily by subcutaneous. That's the route, subcutaneous infusion over 24 hours. So there are no more items on this. Sometimes we have to cross out the prescription sheet. So I'm bringing in the typed prescription because In private pharmacies, that's what they use. I mean, in private practice, that's what they use. And here in government, we now have CMIS. We do have some of the narcotics, especially morphine. Morphine is now there on CMIS. You can use a typed prescription, but make sure that you print it out and then sign it with an indelible marker, or you can use a pen, and then you should also stamp it. Make sure that it has the institutional stamp. So in this case here, they have the address and every detail for the prescriber and the date of the prescription. When was this prescription written? So that that makes the prescription valid. Next slide, please. So here we want to go into detail about the requirements for prescription. Prescription of opioids must be indelible, meaning you should use a pen, a marker, or whatever that cannot be erased. It must be signed by the prescriber, include the date on which they were signed, and specify the prescriber's facility and title. So a typed prescription is acceptable, but the prescriber's signature must be written on it. So for liquid, the total volume in milliliters in both words and figures of the preparation to be supplied should be written. And for the dosage units like tablets and capsules or ampoule, state the total number in words and figures of the dosage units to be given. Next slide. So for opioids, we know that they're subject to the prescription requirements. We must also state the name and physical address or ward of the patient. Physical address for our mobile units, so you should know where the patient stays, so that when this order or when the drug is delivered, you know that you are delivering to the right person. For institution with inpatients, so you should know the ward where you are supposed to deliver this drug and the patient, especially for inpatients. Also include the bed number of the patient. So that is, and also to avoid ambiguity, where prescription requests multiple strengths of the medicine, each strength should be prescribed separately. Morphine comes, IV morphine comes in two, pardon me, I will use morphine IV because that's what I normally use. It comes in two strengths, the 10 milligram strength and the 15 milligram strength. So you should specify if you want the different strength and we are writing the prescription, you should specify So this is an example of tablets. If you want 10 tablets of 10 milligrams, just say that. So the dose must clearly be defined, and then the instruction 1 is directed. It is a dose, and it constitutes, the 1 as directed constitutes a dose, but as directed does not. So you should specify how many, because when you say as directed, it could be 2 as directed or 1 as directed. So you should be careful when you are writing there. 2 as directed or 1 as directed. Some doses you need to take 2 tablets. Yes. It is not necessary that the dose is stated in both words and figures. So the milligrams, the 100 milligrams, 10 milligrams, so mg is enough. So you then don't need to then expand. So a pharmacist is not allowed to dispense a controlled drug unless the information required by law is given on the prescription. So do not be cross with the pharmacist when they return your dose. I mean, we already return your prescription and ask you to be clear on what you want them to dispense. So it's required by the law. So then the prescriber's responsibility. As a prescriber, you should be responsible. A responsible prescriber knows these following things. So in order to minimize the misuse of prescription, records of serial numbers received and issued should be retained for at least 3 years. So usually prescriptions, they come in duplicate or triplicate forms, and those forms have serial numbers there. So when you take the original and the duplicate, there's also another one that remains in that stamp. So make sure that you keep those stamps for at least 3 years in the hospital archives, so that they can be, when there is a case, they can be retrieved. So prescription forms should not be left unattended and should be locked in a secure drawer or cupboard or carrying case when they are not in use. When we are issued with a prescription form, make sure that you keep that prescription form safely. We have seen questionable prescriptions by questionable prescribers that are dispensed, and then later on you find that it was stolen from somewhere. So if there is a certain book with certain serial numbers that was stolen, make sure that you report that to the police so that the culprits can be apprehended. So doctors, dentists, and surgery stamps should be kept in a secure location, separate from the prescription forms. So if you have your prescription form, make sure that this locker is for prescription forms and another locker for your stamp, because once it's found in the same place, so it's easier for people to misuse that one. And we have seen doctor stamps, prescriber stamps being stolen, and they are illegally used in illegal settings, but they get the drugs from pharmacies easily, because they are able to produce a valid prescription in courts. Yes. Next. So alterations are best avoided, but if they are made, the best practice is for the prescriber to cross out the error, write the initial and the date of the error, and then write the correct information. But if the error is made in a prescription in such a way that it cannot be corrected, you just put a line through the prescription and write spoiled or destroy that form altogether and start writing a new prescription. So compliance with all relevant legal requirements is paramount when dealing with prescription of opioids. Thank you very much. In conclusion, I can say that there is a law governing the prescription of opioids, but they should not, those laws should not stop us from treating our patients. So institutions, drugs and therapeutic committees in institutions, they do have local policies on how to prescribe and who should prescribe an opioid. Imagine in a clinic setup where there is no doctor, and then the opioids are there, but there's no one who's going to prescribe. There should be someone that is overseeing the prescription of opioids, but we should try to have policies that allow the opioids should be to be accessible. Like we can have a doctor prescribing an opioid, and then we have a policy that allows nurses to refill those opioids for the doctors. I mean, for our patients, so that the opioids can be accessible. We hope these laws and restrictions are going to be revised, and as colleagues, we should advocate, especially for safe drugs like morphine, so that we can all be able to take care of our patients and control pain without being restricted by laws as old as that one from 1922. Thank you very much, colleagues. I hope to have more questions so that we can discuss together. Thank you very much.
Thank you, Mr. Mvila, for the enlightening presentation. I think it was clear to everyone what the presentation was about, and you did raise some great points. For me, I was able to learn that prescriptions, taking it from the principles of opioid prescription, I was able to pick that individualized treatment is very important to consider for the clients, and doing so by following the WHO ladder. And also that the prescription of pure drugs is recommended for easier titration. So at this point, colleagues, I will open the opportunity or give the opportunity to anyone that wants to ask any question. Like Mr. Vila said, he's hoping for this session to be more of a discussion than a lecture. So at this point, anyone that has a question, you can use the raise of hand or use the chat box, whichever you are comfortable with. Any questions or any comments, this is the time to come forward with such. Are there any questions or comments? I'm seeing a hand from Mr. Mashango.
Yes. Thank you so much, Mr. Vila. Today it's a really an eye-opening presentation. You know, in the country, I remember one time we went to another retailer providing these drugs. We were requesting the pure codeine, the 30 milligram tablet, but they said they don't have, and then they gave us paracodeine, the codeine, the one with the Panadol 500 milligram and 9 milligram of codeine. You know, I'm just worried, you know, the challenges our clients are going through, that now with this fixed combination of drugs. What can be your advice in terms of this? Should we have more of such in our stocks, or should we have tramadol if then we can't have a pure codeine? Because really, you will find that a patient is on paracodeine for a long time. And then you find that the healthcare worker has been prescribing that paracodeine with only the mentality of the codeine behind, and you know the challenge that come. I don't know what can be your advice in terms of stocking such a drug and prescribing. If then there is more of paracodeine, yet you want to control a moderate pain, should we opt just straight go for tramadol instead of having this combination, which might not be able to titrate? And then I have another one from Tandazile here on chat. He is saying, thank you very much for the presentation, Mr. Mvila. And can you please clarify once again on the 10 milligram versus 15 milligram morphine?
Thank you very much, Mr. Mashango. Yes, you heard me right. Paracodeine, when you give paracodeine and you want the effect of the weak opioid, the codeine there, you are likely to overdose your patient with paracetamol, like you have correctly said, the strengths of each drug in the combination. So like you have already said, it's best to then, if you don't have codeine, pure codeine, and you want to titrate your drug, it's better to switch to tramadol. Tramadol, you find the pure form of tramadol, and then you give tramadol, and paracetamol, of course, like we said, and also an NSAID on the side. You give your adjuvants as well. But if you are to then look at the availability of codeine, usually codeine is the stocks are limited. So if you find codeine, it would be for that month and that month, then it is not there. So most pharmacies, they order paracodeine instead. Even under our system here, CMS, when we order our paracodeine, we order paracodeine, but when we order codeine, you find that usually it's not there or there is limited stock. So like you said, switch to tramadol for your weak opioid. Thank you very much. But when now coming to the 15 milligrams versus the 10 milligrams of morphine, yeah, those are the forms of drug. This one is an injection form. So, and then now you have 10 milligrams ampoules of morphine. You also have 15 milligrams ampoules of morphine. If you are in the ward, you are ordering your drugs. Pharmacists, they keep different registers for these drugs. So if you order, you must know that you want them to supply you with the 15 milligram of the drug, or you want them to to supply you with the 10 milligram of the drug. That is what I had alluded to. But for other drugs, maybe going further, like for example, morphine. Morphine, the oral strengths, sometimes you find 5 milligram in 5 mils. You find 10 milligrams in 5 mils, that is the oral morphine, or 20 milligrams in 5 mils, or even 100 milligrams in 5 mils. So you should know, don't just say 5 mils when you order. Be specific that it's 5 mils of the 10 milligrams, 5 mils of the 5 milligrams. That's what I was trying to clarify there when it comes to the different strengths. But you find that it's just an ampoule. If you say one ampoule, what strength? Thank you very much.
Thank you.
Thank you, Mr. Mvila, for the clarity on those questions. I believe our colleagues have been answered. I'm also seeing some comments in the chat section. There's a comment from Thandazile Simelane, which says, acts and protocols. What are the legal implications of nurses making opioid prescriptions as backed by protocols versus acts? On the issue of strong opioids for pain control versus addiction at the end of life, which takes priority. So she has 2 questions there. I don't know if you're able to follow, Mr. Mvila.
Yes. Yes, I'm able to follow. That's why I said when it comes to the acts and protocols, that one I want us to discuss that, because we can always advocate for our patients. We can always advocate, nurses can always advocate for their practice. So if they really want to practice, then we need to, because acts, bills and all that, they are informed by what is the obtaining in our different settings. Like I said earlier on, the 1922 Act, I don't think there were nurses who were as qualified as the nurses are qualified today by that time. Mostly there were lay nurses. Mostly there were nurses with minimum qualifications if they were professional nurses at that time. But for now, we have nurse specialists with master's degrees, PhDs in the different fields. So how then do you justify to say you should wait for the doctor to write a prescription? You should wait for the dentist to write the prescription, and yours is only to give the drug once the doctor has written the prescription. If you are to prescribe on your own, you should be regulated by certain policies that will make you covered. So maybe I'm answering the second question now. The regulations and protocols, they allow the SMO of that institution or that specialist doctor in that department, like an ICU, the intensivist in ICU. It allows them to cover you in a way because you are practicing under their supervision. They are there to cover you when there are litigations and whatsoever happening. So, but we have nurses in private practice. They are practicing on their own. Should they be restricted to going to where there is a doctor to sign those prescription forms? So let's discuss, colleagues, and we will then know what to do, how to advocate for these laws to be flexible to us in the modern times. Thank you.
Thank you once again, Mr. Mvila, for that clear response. Just to go back a little bit for Thandazile on the question about addiction. In our previous session, our guest lecturer did get into detail about addiction of opioids. In the session was about assessing the risk for opioid and substance abuse. So I can suggest that you can go back to that session and look at that presentation. I think you'll get even more clarity than probably what we have also covered today. There is also a question in the chat box, which says from Magagamete, are the acts and regulations sold in the Ministry of Health or any other place? I noticed that there was a race in the patient description. Does race carry a significant identifier for a client?
Yeah. Thank you very much. May I quickly answer the first one? Acts and protocols, the Ministry of Justice, but I'm forgetting which department exactly, where you can lay your hands on that one. And also go to the government website. I didn't look at it, but I was advised that go to government website and go to Ministry of Justice, and they have a list of all the acts in the country. I don't know whether it's downloadable. I don't know. I will also try after this session. But the Ministry of Justice, they do have, and they say there is no excuse in not knowing the law. That's what they say. So we should, as professionals, we should familiarize ourselves with. And I've mentioned just a few of these acts. There are many of them. The Nurses and Midwives Act, whatnot. All those acts, you need to familiarize with that yourself with those acts. And then coming to the description, race, patient description, race. Yes, there are, okay, it's not specifically for opioids, but there are requirements that you know such diseases which are more prone to affect Africans than Caucasians. So there are restrictions, there are reasons why you should also put that race there to say this one was an African, this one. So most of our forms, maybe we have not noticed, most of our forms, they do specify, are required that we specify whether the patient was an African or a Caucasian or an Asian. And also we know our physical makeup as a certain race. Like for Asians, usually, especially the Chinese, they are of small stature, and Africans, when you compare them with Asians, they are of big stature. Of course, that one can be covered by the weight size, but I have an experience with doctors from Taiwan who came here. They were prescribing low doses. And then we told them that, no, there's a different race here. It's a different race. So for Africans, these doses are not adequate. Thank you very much.
Thank you so much, Mr. Mvila. I think we also do have another question from Eswatini.
Thank you, Mr. Mvula, once again for the informative presentation. I only have one question. I want to ask that, let's say now I have to prescribe Paracordine together with paracetamol for some reason. So considering that Paracordine contains the paracetamol, what would you advise that I do? Because with the Paracordine, there's 500 milligrams paracetamol and 80 milligrams codeine. So what do I do? Do I give only one tablet paracetamol to add on the existing 500 milligrams so that it makes it 1 gram? Then if I do that, what about the dose of the codeine? Because it's only 8 milligrams. Considering that usually most guidelines, they say to give 15 to 60 milligrams. What would you advise that I do? Let's say like as a hospice nurse, I'm already in the field. What must happen?
Thank you so much, Tana. You rightly said that Paracordine has 500 milligrams of paracetamol. Yet the codeine dose is very small. So even if you double it to 1 gram, you still have a small dose for codeine. It's not adequate, like you have correctly stated. So I don't know why you would want to add paracetamol on Paracordine. But what I would advise that you, like you said earlier on, that you don't prescribe the Paracordine at all if you feel strongly about giving your patient paracetamol. You just give tramadol and then you give paracetamol on the side. So as different pure strength, that is what our lecture and discussion is about today. But if you want paracetamol 1 gram, just give 2 tablets as directed of paracetamol of paracetamol and codeine, that is Paracordine. So you'll have 1 gram of paracetamol there for your patient, but still the codeine, it's a small dose. Thank you.
Right. Thank you, Mr.
We are going to take one last question from Thandazile Simelane, which says the question of addiction is of a case whereby you have done your assessment, ascertained that indeed there is addiction. However, the client is at the end of life and reports severe pain, breakthrough pain even. The question then is, which concern takes priority at this stage? How do you go about dosing?
Taking care of breakthrough pain, or the general principle of how you prescribe your opioid. I don't want to say morphine because that's morphine that we normally use, or we usually use. So your opioid, taking care of breakthrough, it's a lecture on its own. I hope Mr. Matlangu has it lined up here so that we can, I nearly included it in this discussion, but I saw that it is going to take the whole time. But the breakthrough pain, you should take care of the breakthrough pain by adding half of that dose. And I have it here in front of me. So you increase the regular dose by 30 to 50% of the previous dose if pain is not controlled. But then you add it to the daily dose of the patient, and then you increase the 4-hourly doses of the patient. So in order to explain it very clearly, you need to know that. But you said, what do you take care of first, or what is your priority? Under palliative care, our priority is to make sure that the patient is comfortable as possible. So we take care of the pain. we are aggressive with pain management. Of course, we do consider the patient's condition because we don't want to overdose the patient to the point that we are assisting the patient to pass on. Remember, we neither prolong nor hasten death under palliative care. So, but we don't want a patient, we don't want to deny a patient analgesia because we are concerned about other things. We want to make sure the patient is comfortable and then we take care of other things. Thank you.
Thank you, Mr. Mvila. I hope Thandazile has been answered. This is a very interesting topic. I wish we had more time to cover all the aspects and all the questions that my colleagues have on them. But in the interest of time, can we move on to our case presentation by Nondukuzo Tani?
Thank you.
Good evening once again, colleagues. Our case today is from the Home region. Presenting is Nondukuzo Tani. Our client is a 77-year-old female. She is a new case. Her diagnosis is hip dislocation. The client's main problem is that she is bedridden due to hip dislocation, which has now resulted in several complications and has limited her activities of daily living. The concern is that as much as the client has been bedridden for such a long time, she adamantly refuses to go to hospital to consult a doctor, yet her condition is worsening day by day. The chief complaint, when the client called, they were requesting that the client be done catheterization due to the fact that she is immobile. Also that she doesn't have many disposable nappies, so they felt like if she had the catheter on, maybe if the urine goes into the catheter, they could be able to save. The other complaint was loss of appetite for about five days at the time when I saw the client on the 11th of January, and also reduced bowel movements. She also has pain on the hip joint and has developing bed sores on the body. She also has lower abdominal pains when urinating, which are accompanied by strong frequent urges to urinate. She also has developing pressure sores on the heels, sacrum, and the back of her shoulder. She also complained that she has difficulty attending church now as she used to due to the illness. On assessment, the client has impaired hearing, has poor skin texture and sunken eyes. She has pressure sores on both heels, sacrum, on the left back shoulder, which are all at stage 2, meaning they are open but not deep. The client also has white scar-like patches which are thickened and crinkly, accompanied by a foul odor on the perineum. On the client's medical history, the client is a known hypertensive since 2010. She had a COVID infection on March 2021, has also had a dislocated hip since June 2022. She was on a hip traction from June to August 2022, which means she had it for about 2 to 3 months. And then she also had cataract removal surgery on February 2022. The client's social history: the client is unemployed. She is a housewife. Her education ended at primary level, and she belongs to the low socioeconomic class. The client is married. She has no history of substance abuse. On relevant conditions of family members, the client reported that her mother had hypertension and diabetes. The client, we haven't done any do not resuscitate orders, and there is no living will, and the advanced decision to refuse treatment, it hasn't been done. The mental status of the MSE for the client was done, and the client was found to be well-oriented to his fears. The only concern would be that the client spends prolonged periods alone when the family is away for the day, which is not quite good for her mental health. On the systems review, the client's vitals were almost normal except for the BP. The temperature was 36.2 and her BP was 150/90. Pulse was 88, respiration 17. Unfortunately, we couldn't take saturations because we didn't have an oximeter. The pain scale was found to be at 6 and the epoch functionality status at 3. Some of the other symptoms the client had, according to that scale, pain was set at 3. She also had anxiety, which was mild. Depression, I would rate it from mild to moderate, but yes, I did write the moderate because we didn't have, we haven't had many visits with the client. It was only the first visit, so I couldn't gauge very well. And also she had anorexia, which is mild, and also poor mobility, which is overwhelming. The client's relevant past medications are HCTZ 25 milligrams OD. The current medications are still the HCTZ, diclofenac, paraquat, omeprazole, calcium, amoxicillin, ORS, and multivitamin. On the pain assessment, the client reported to have pain on the hip, which is chronic. She described that it is aching and throbbing, rated at 6, and it is constant. It is usually caused by movement and relieved by medication and rest. It does affect sleep and it does affect mobility. On the effect of the current medication, I wrote that the client isn't yet on medication because I found that she didn't have any medication. The last she had was the time about 2 or 3 months ago when she last visited the hospital. Also, on the second pain assessment, the one on the lower abdomen, the pain is acute, it is burning. At a rating of 2, it is intermittent and it is caused by when she is urinating, it is relieved by bathing. She said with cold water or ice cold water. It doesn't affect sleep and it doesn't affect mobility. And she also isn't on any medication for it. And then on the pain evaluation form, the client has only been assessed once for pain since she's been visited only once. On the 9th of January this year, she had pain on the right hip, which has at a scale of 6, which is severe, and she's had it for months. It is due to the bone dislocation. She didn't have any treatment yet for the pain with her. I found her with pain. So progress following intervention, the client is yet to be reviewed after a week, which should be on the 17th of this month. That should be next week, Monday. Also, we couldn't do focus lab investigations. The further plan for the client was to continue sensitizing the client on the importance of consulting a doctor. Because according to her, she said she cannot go back to hospital as she has been in and out of hospitals without any assistance. And most of the doctors, they were actually saying they are seeing nothing wrong with her hip. And they say that they are just putting the traction to ease her pain. Otherwise, they didn't see anything wrong with her hip. And to also address her spirituality issues, as the client realized that she could no longer go to church due to the illness, yet before she would go occasionally every Sunday. And also, as a side note, the client on the spirituality issue, as a side note, the client is not very impressed with what happened with her, because she said the illness started when she was going to church. She just slipped, but she didn't fall. And then she went to church. After the service, she couldn't walk. So that was the last time she was able to walk by herself. So she seemed angry as she feels she got injured twice going to church, yet she feels that shouldn't have happened as she was going to church. And also, part of the further plan is to continue managing the pressure source so that they heal. That will include educating the client also on healing strategies like the using of credit, positioning, nutrition, etc. And also educating the client and caregiver on perineal care and hygiene, and also to provide clients with sanitary material like linen savers and gloves, and also to do further pain assessment and properly intervene as needed. And also asking the client to provide a form of distraction for the client for the times, for the periods when she is alone, like a radio, it is cheap. And also to review the client after 7 days, and also to continue educating client and the caregiver on general health conditions. So that is our case for today.
Thank you, Nonduduzo, for the case presentation. A 77-year-old client who has a hip dislocation, who is not willing to go to the hospital and seems to be having certain anger issues with regards to spirituality. So what would we advise, or how would we advise Nonduduzo to better manage this client? Colleagues, do we have any questions or any comments on how he should manage this client? There is a comment from Maggie Hamini on our side.
Thank you very much. I think I will first start by probing further on why is she not willing to go to hospital? Because you might find that there is something that is causing it not to want to go to the hospital. We should get further management of this location.
Thank you, Ms. Lamini, for the question. To answer that, first, the client said she was admitted to one hospital where she had repeat visits, and they kept saying they are seeing nothing. And they eventually put her on traction for the 2 to 3 month period, which didn't help to relieve the pain, and also she couldn't gain her mobility back. And then she went to another hospital after trying some few more. She went to another hospital where they admitted her, and she didn't get any help because they said she must stay and wait for their specialist to come. And she ended up being discharged without the specialist coming. Then they said they would call her when the specialist is back. But when they did call her, she said she spent money hiring a car and going to hospital, only for them to say they were just going to examine how her cataract removal surgery went. And then the third reason was that she doesn't really have the funds, because now she has to hire a car since she is immobile. She has to hire a car to go to the hospital. So since her family members were there, especially her children, we tried to discuss with them how they can help their mother to go to hospital. They say the car is there, they could only try to find funds for the petrol to take their mother to hospital, but only once she agrees. Because they said she just seems to be agreeing in front of me, but otherwise once I'm gone, she will just completely refuse, because she says even if she goes to hospital, she doesn't get any help. I hope you are answered.
Yeah, for now, I think we should going to maybe talk more on how to convince her. Because for now, she may agree when you are there. But as soon as you leave that place, she goes back to the decision not to go to the hospital because of the experiences that she's doing. How are we going to address those experiences? How are we going to help her? Maybe try to forget what she's been through in hospitals.
Thank you, Nkosi. I think you are raising an important point of how we could help the client move past some of the experiences that are making her not to want to go back to the hospital again. Do we have any comments or questions, colleagues, on how this client can be better managed? Mr. Mashamo.
Okay, thank you. Another thing I'm seeing here is the issue of I don't know what this is called in family stages. But again, I will just summarize it: a neglect, because most of the time, 77 years bedridden and left alone. That alone gives the patient the feeling that I'm no longer needed. And then it makes it that even if the family members wants to do something, she feels like they don't love her. I think another approach would be getting to know the family members and have an agreement on what role they can play. After maybe we've got to find what really are the goals of care for the patient, what the patient really wants at now at this time, because we may push it to hospital only to discover that spiritually issues of hospital are not hers. And I've seen that she is a person related to a church, and we don't know, are there any resentment? And actually what she defines the hip dislocation to be, or what is the underlying cause to the condition in Lagio. So I think that also will help us to know which side will help the patient. And now I've seen that the patient is sacral pedsole, heel pedsole, you see. Now the patient is becoming so terrible each and every day. So I think the issues of support in terms of caregiving, family meeting will be so supportive. I think if a psychosocial person can come to resocialize. Another thing I'm seeing, the patient is already hopeless. She feels like there's nothing that can help at all. So she's right where she is. But I think sitting down with the patient, it will call for a lot of hard work and a lot of advocacy for this patient, because once you promise the patient for hospital, you need to be sure when she went to hospital, she won't experience the very same thing she was told. She will go straight and get the answer. So I think maybe meeting one of the, either we need a surgeon or we need a medical officer, someone will address, because now we have a comorbid inside. We have a bed sore, now we have all this. So, and there's also diabetes or HTN inside there. So I think that also will help. Then establishing the support at home.
Okay, thank you, Mr. Masam, for the question. I just want to add one more question for Nonduduzo, which is slightly related to what Mr. Masam was saying. I want to find out if the client mentioned that she has had visits from the spiritual leader or just the brethren in general. And I also want to ask that the relationship that the client has with her relatives or family members, is it the reason that led to you guys not having the proxy decision maker conversations? Was she not willing to engage, or? Yeah, those are the questions I have.
Okay. Thank you, Mercy, for the question. Okay, the client did state on the spiritual visit, the client stated that none of the church members were coming to visit her currently. At first, they did come, but now they no longer come. So she doesn't know if it's the fact that sometimes she goes to visit her sister for extended periods so that the sister takes care of her. And then they usually didn't find her at home. So she's not sure if they were discouraged by that. And the second question.
On the proxy decision.
On the proxy decision making, it was my first time seeing the client. So we still had many issues to discuss. I felt like there are others which could come first, could be prioritized. Then maybe on the following visit, we could discuss that. And also coming back to what Mr. Mahlangu contributed on, it was very insightful, his contribution. Also on the family being away, she said it's not necessarily that she's being neglected, but it's just that her children have to go to school and her husband has to go to work. And some of her other children are also working, so they cannot see her as frequently as they would like. So you find that during the day she is alone, but in the evening they are back and they do take care of her in those ways in which they are able. And also her goals of care, the client said she would like to be able to regain her mobility. Hence the sensitization that she has to at least try and go back to hospital if that is what she wishes to happen. And also the cause of the dislocation, it might be another cause in a way, since the client, she started crying when she expressed how she got injured, because she said she was going to church and then she only just slipped, but her daughter was near to her and she was able to catch her before she fell. Then they went inside church and worshipped, but she had minor pain on the hip, only to find when the service was done that now she cannot go. So she said now she doesn't even know how she will even pray, because she feels like she got injured while in church. So she has almost lost her faith there a bit. So we did try to talk about it, but I could see that, yeah, it really needs extensive help. It was more than the sickness could handle. So I think she does need a spiritual person to take care of her. Also that now her main problem is that she says she needs a catheter, which I can also see, but the problem is that on the examination, especially on the perineal examination, and also that she reported that she has burning pain when you take. So that signals an infection. So I couldn't insert the catheter. Hence I asked that if when she goes to hospital, she can also address that with the consultant she would see, because then she'll be able to have lab tests done and also the infection will be properly treated, since she will know what type of infection it is. And also when I was examining, besides the burning pain on the abdomen, she had white patches on the perineum, white patches which didn't have a defined border. They were crinkly, like when you've had your hand for a long time in water, like it's wrinkled, like it's dry of water. So according to what I know that it's a Lynchon sclerosis or something, but it's something I wouldn't say I'm familiar with, hence the more sensitization that she must go to hospital. And then I explained to her why I couldn't insert the catheter as per her request.
Thank you, Nonduduzo. I am not sure if anyone still has questions on the case. Yes, Mercy.
Thank you very much. It's not a question, but I noticed that on my application there is paracoding, and then on the chief complaint there is reduced bowel movement. I was hoping there was something that you did to address the issue of reduced bowel movement with regards to the paracoding.
Thank you for the question. I did on the promoting general health measures, I did emphasize on just general, like reducing salt, reducing fats, and also that she must at least take 2 liters of liquids per day, because we did expect, as a nurse, I did expect the reduced bowel movement. But as long as she does have bowel movements, because they are reduced due to the fact that she is now immobile, so bowel movements will reduce, and also due to the fact that she has low appetite, because she hadn't been on paracotin before, since she said she didn't have any complication. So I did emphasize that she must take adequate fluids, enough fiber, and also try to eat, especially with now that I had given her the multivitamin, and also tried to talk to her that maybe she will have that appetite. So after when I follow up, I will follow up on that also to see if it has improved or not. Then if it hasn't, then maybe we could employ other strategies.
Thank you very much. I think it's a good start for me, but then I hope on our next visit we shall be addressing the issue of immobility. When it comes to the reduction of appetite and reduction of our movement, and then the effects of some of our drugs to that, and how to address it when the patient is complaining and suggested that should be catheterized, while we come and say you need to drink a lot of water, and to her she would say that as long as I drink the water, I'll be needed to urinate frequently. So she will not take the water and she'll be constipated because you also refused it. To her, it would be like you refused to catheterize me while you want me to drink your water. Because those things come to be yours and mine, yours and mine. I wanted a catheter and you wanted me to drink water. So I cannot drink your water because you refused to catheterize me. But then I think we shall be developing our relationship so that she trusts us and we trust her with the information that she gives us and the information that we give her to help us.
Thank you, Nkosi, for that contribution. In the interest of time, we are going to come to the end of our case presentation. I will quickly go through two comments in the chat box. One which says team approach is very important in pain management, even at end of life. All drugs need to be reviewed as the goal is to use minimum effective dose. In difficult situations, it is important to seek a specialist's advice. And also prioritizing the therapeutic goal is key, and use of non-drug approaches is useful at the end of life. We hope to cover more in pain management in the coming sessions and modules. Thank you, colleagues, for joining us in today's session. We hope that we were able to cover so much ground, and we are going to fill all the gaps that we have identified in our line of work. We have shared a feedback link in the chat box, so can we click that feedback link before the end of the session so that we can give feedback on how today's session went. Our next session will be on the 25th of January, where we'll be looking at prescribing short-acting opioids. So thank you for joining us once again, colleagues. Do have a lovely afternoon. Thank you.
Thank you. Thank you so much. Today's materials will be available in our ECO platform. You can check them an hour later for today. And also you can also visit our YouTube channel to view these videos. They are also available there. Thank you so much. Let's meet on the next session, which will be the second one for this year. Thank you.
Bye, everyone.
Thank you everyone for joining. Hi team Eswatini. A very happy new year to all of you.
Thank you, Arlene. Happy New Year with your team too.
Thank you so much. So as I mentioned, I would like to introduce one of my team member, Malaika. She will be supporting you with the rest of your sessions in the coming months. Malaika, would you like to please introduce yourself?
Hello team, Malaika this side. I am an executive in Echo India, and I've been working with Echo India since last 8 months. And thank you, Alina, for introducing me, and I'm happy to be part of the team. And yeah, today's session was very informative. Thank you so much.
Thank you, Malaika. If you could kindly open your video as well.
Thank you. We are welcome and happy to have you this year again.
So Kriti, do you have anything else to add? So Kriti, you're not audible.
Miss Fatani, I think you don't know me. I am working from the background and working as associate manager with India from quite some time now. Just turn on my camera. I hope if it works. Hi. So there has been some transition that my colleague Alina is going to be part of the other African groups, and Malaika, who was earlier part of other team, she is going to be taking care of the Eswatini hub specifically. So I hope she's going to continue in the same way in which Alina has hold all of you. And in case of any queries, you can happily reach out to us. Malaika will always be there. If she's initially she's not able to, answer the queries, Alina is going to be there with you, and I'm also going to support you from the background. So yeah, that is it. Malaika, if you are able to turn on your camera so that people can actually recognize, oh, your camera is not working. That's fine then. So yeah, that was it from my side. Thank you.
Thank you, Sukriti, and it was really wonderful working with the Swati team. You guys are doing really well, and it's lovely to see that you are able to host your sessions on iEcho now. And you can reach out to me whenever you have any questions or anything I can support you with. Malaika will be there for the next session on 25th.
Thank you.
Thank you, everyone. See you. Bye-bye.
Bye-bye. Bye-bye. See you next time.
Bye-bye, everyone.
Bye-bye.
Thank you, bye.
Yes.